I was watching the Winter Olympics and a story about the 1988 Jamaican bobsled team came on. The story was about a team of unlikely people who were persevering through all sorts of challenges and nearly impossible odds to do something incredible, something they all believed in. They'd never had a team before. They didn't really even have bobsleds on the island, let alone snow or ice or mountains. Yet they had a vision, a real belief in achieving their goal, even though to most people it seemed like a moonshot. Today's episode is a similar set of passionate individuals, each with a big vision, an unlikely vision, a bit of a moonshot of their own. The odds may seem stacked against them, but similar to those Jamaican bobsledders, I'm excited to root them on, and I think you will be too. Welcome to the Dose of Optimism, where I talk to the optimists in healthcare. My name is Omkar Kulkarni, and I work at one of the world's best children's hospitals, where I lead innovation. I started KidsX, which is a premier international startup accelerator for pediatric innovation, and over the years, I've met thousands of startups, investors, and innovators. Every one of them has a story, and every one of them is optimistic about the problems they're solving. On this podcast, you'll meet amazing people who will share their stories and what makes them optimistic about the future of healthcare. A little note before we get into this episode. This podcast is for informational purposes only. We are not offering medical advice, and we're not endorsing any products. Please talk to your own physician about your health or the health of your children. All right, let's get started. My first interview is with Dr. Timothy Chou. He is a pioneer in cloud computing. He was an executive at Oracle, serving as the first president of their cloud computing business. He returned to Stanford University in 2005, and he started the first class on cloud computing there. He's the head of the Pediatric Moonshot. It's a really bold and ambitious global initiative focused on reducing health inequity and improving outcomes for kids by connecting the data from over 1 million different healthcare machines around the world, things like ultrasounds, ventilators, gene sequencers, things like that, across the 500 plus children's hospitals around the world. Again, big dream, big moonshot, but you'll hear from him. He's got a plan, and he's got quite an interesting idea about how to get this done.
Omkar, thank you for having me on your podcast. Let me start with, I have no healthcare background, none, zero. I retired as the first president of Oracle's cloud computing business. I went back to Stanford, started the first class in cloud computing there. And it's now, I don't know, 8 years ago that a strange student arrives who wants to meet the professor. So I meet him for breakfast. I discover he has an MD, an MPH, an MBA. He's chief of pediatric cardiology at the Children's Hospital of Orange County. So some of you may know Anthony Chang. Anthony, I looked at him like, I don't know anything about what you know about. So why are you talking to me? He says, well, I felt like AI and big data and cloud computing needed to meet. And so the way I say it is Anthony adopted me. So I started learning things about your world. Oh, you're kidding me. You're still using CD-ROMs? Yes, I know. And then at the other end, as I think everybody knows right now, the only way you can build accurate AI algorithms, agents, et cetera, is you have to have access to large quantities of diverse data. Otherwise, you can't pull this off. So that's why basically during COVID, I'm sitting around thinking, oh, watch Netflix all day or maybe do something useful. And so I got a team together of engineers and people I've worked with in the past, and we gave ourselves a mission to reduce healthcare inequity, lower cost, improve outcomes for children locally, rurally, and globally. So how are we going to do this? By creating real-time, privacy-preserving AI applications based on access to data in all 1 million healthcare machines in all 500 children's hospitals in the world. And that is what we call the Pediatric Moonshot.
So, first of all, glad you did not exclusively watch Netflix during the pandemic and you made this your passion project. Let's talk about rural pediatric care a little bit. It struggles often to keep up with the needs in terms of access to specialists and advanced diagnostics. The way you're thinking about AI and the Pediatric Moonshot, how do you think it could help address some of these gaps?
Yeah, well, I think it's really, in some senses, it's the whole purpose. We like to say, if your mom works for Google and you live in Palo Alto, stuff we're working on is interesting. But there's plenty of kids that is not the case. You may already be aware of these statistics. 60% of the rural counties in the United States have no pediatric expertise whatsoever. 3 states actually have no pediatric emergency physicians. In the US, we have 3,000 pediatric cardiologists, by what I just told you, all living in the major metros like where you and I are. If you go to India, there's 300, and if you go to Rwanda, there's 1 guy. If you think about it, you go, "There's no way we can use the conventional mechanism of building medical schools and hospital, all this sort of stuff to be able to address this scope of needs." But what if we could take the best and brightest brains, if you wanna think about it that way, and put it at the point of care? So we've been looking at, in essence, a couple of very basic kinds of applications. So remember, I made the comment about 1,000,000 healthcare machines. One of the things we started out with was imaging machines because there's a ton of data in imaging machines, ton of real-time data sitting in imaging machines. And so now, and if your listeners are curious, go to appcommons.bevelcloud.ai. You'll see 140 research projects out there where a group at Mount Sinai, at Stanford, at CHLA might have gotten 1,000 ultrasound images and built a congenital heart disease detection algorithm, right? Which, given the architecture we built, could run at the point of care in the building in Willits, California, which happens to be a rural population of 5,000 people. And now that expertise, if you want to think about it that way, in oncology, cardiology, emergency medicine, can now be deployed at the point of care in real time so that the kid walks in. You could do early brain bleed detection. There's hundreds of applications. And as I said, at App Commons, you can see a set of these that have occurred in the research realm, which now I can deploy out at the point of care. Let me give you another one that we've been working on, which is disease precise AI agents. So one of the things the architecture enables us to do is build what we're calling digital twins of patients, patient digital twins, which now, again, I could privacy preserving, I can run in the building in Willits, California, or a clinic or a hospital or an imaging center anywhere in the world. And now I can pull the data and train and create a digital twin of the patient. What could I do with that? You may already be aware of this. The pharma industry has moved progressively to building more specialized drugs. FDA calls these orphan therapeutics. Orphan therapeutics affect only 200,000 people or less. We are tracking 60 diseases in kids which have approved therapeutics that have been approved over the past 2 years. Conditions like HAE, in fact, I'm gonna talk to somebody about that today. You look at these, how there's an approved therapeutic for HAE. How does the guy who's never been trained in pediatric immunology ever gonna figure that out? The way we look at it is I can build an HAE agent which sits there and knows in essence, 34 questions I can ask the patient digital twin that together will give me confidence that indeed this patient has this condition. Again, I can run this at scale globally everywhere. So I think the implications are really that, to your point, not the kid doesn't need to be moved to CHLA, or if the kid does, then we know exactly why we're doing this. And we can up the level of care using computers, using AI, and not have to figure out how we create tons of medical schools and incent a doctor to go live in rural California.
How do you get adoption? So how does the clinic in California or in India or Rwanda, how do they actually get these software platforms? How do you actually drive and enable adoption across all these different places? How do people hear about it? How do they make sure they have access and the right cloud infrastructure?
So first of all, Once we went into this, we went, okay, how are you going to build AI applications? The current state of the art is you go bring power to run training for all that data. By the way, that's the whole conversation everybody's hearing about ChatGPT or Claude or any of these large language models is all based on that fundamental architecture, which is bring the data into some central site. And we said, never going to work in healthcare. Number one, data sizes are much larger. Ultrasound studies are a terabyte. We've actually done the back of the envelope. The 500 children's hospitals generate 6 million terabytes of data a year. That's
Wow.
just cardiology, right? Okay, data size much larger. Number two, security requirements much tougher. And number three, privacy requirements much stricter. People may already know this. Norway's going, Norwegian data is never leaving Norway. Australia has 3 states with 3 different privacy laws, right? So we said, this is computer science 101. We said, rather than move the data to the application, let's move the application to the data. So we have engineered a distributed AI cloud infrastructure, which literally puts a cloud server in the building, to your question, in Willits, California, at CHLA, in an imaging center, in an ambulance, etc., which has real-time access to data coming from machines. I've been talking about imaging machines. It also has, quote, offline access to PACS data, EMR data to enable a whole host of applications that we touched on. So in a lot of ways, the model is very much like how one thinks about Apple. So Apple built infrastructure, a phone, sent it all around the world, gave people access to a camera and GPS information, and then told the world, go build Uber and Lyft and Instagram. We see the world the same way, right? Build out the infrastructure. The camera is now an ultrasound. We actually do have GPS information. And let's go build oncology applications, cardiology, immunology, et cetera, applications. So the step we're in, just for your listeners, we're an engineering team. So we said, let's go do this. So we actually implemented 8 zones in 3 continents because we wanted to make sure this could be a global infrastructure. But the giant question is, how do you learn on a distributed data set, not bringing it all into one site? So there are techniques, we call these distributed learning, federated learning, personalized federated learning, swarm learning, all techniques, which basically are, can I learn on the data inside the building in Willits, California, or at CHLA or whatever, and only share what I learned about that image, which is both privacy preserving and network preserving.
And can you? What's the answer to that?
Yes, you can. We've done work in the lab that proves this is doable. There's actually 3 teams in the world, 2 in Germany and 1 in Australia, who've demonstrated this capability to go do this. But the trick in AI is you can't just do it by imagining it. You have to have real data. So the step we're in right now is we are building a distributed AI lab for children's medicine. It will be 32 sites, 32 zones, all imaging machine data available in real time, all PACS data, all EMR data available, 2 authorized applications, roughly 3,000 servers, roughly 200,000 terabytes of data flowing through it on an annualized basis, roughly 6 million patient digital twins. I've been funding all of our work to date. This step, we've estimated at rough 50 million. So we launched a capital campaign about a month and a half ago to go raise 50 million to go create this first step of being able to do this at scale. And to answer your question, our theory is if we get 32 and we show a lot of what we're talking about as now applications, then finding the 33rd hospital or 33rd clinic is not going to be that difficult. So it's really getting a critical mass of an entirely new infrastructure is really the step we're in.
These 32 hospitals or zones you have, are they mostly in the United States or are they around the world? What's the reach of the first 32?
So we have done zones in 3 continents for 8 sites. We're in the process of raising the money to go do at scale. So when I said we did a zone, I'm telling you what we did is we put a server inside the firewall. We call it twin to a single ultrasound. Now, by the way, putting a server inside the firewall is no mean feat. It's not technically difficult, but you could all imagine the security review, privacy attorneys, et cetera, to go do this. But the beauty of our architecture is we put in one server twin to one ultrasound, the thing completely scales. The same network architecture, the same everything works, whether it's one server or 1,000 servers. So that's the step we're in right now. We know we can raise the money. And I think in the process of raising the money, we will come to some conclusions about who the 32 sites will end up being.
My last question, let's say it's 2030, we're 5 years from now. What's your vision? What's your most optimistic vision about where we are?
Oh, I think we will have deployed what I talked about at scale. Chances are we will have gone beyond 32 zones. I think it's one of those critical mass questions. I think as soon as you get to some level, I don't know, the 32 was quite arbitrary. I think it gets easier and easier, but I'm pretty convinced we'll be at 32 or beyond. I think we'll also have brought a number of accurate AI imaging applications into the world, whether that's research groups bringing them into the world or whether that's independent software companies doing that. And I think we will have pushed the state of the art of how do you build patient digital twins that now can be used in essence as proxies for the actual patient. And now I can run diagnostics all day and all night against all that data without ever taking any time from a physician, the patient, or anything. And I just had a conversation with the CEO of Sick Kids, and he's been talking about precision child health he likes to say, from the genetic code to the zip code. And that's the way we're thinking about it. Let's create a patient digital twin, which is from the genetic code to the zip code. And now if you have that, which we have some of that already, we're already looking at, yes, we can bring in all the EMR data, but as we all know, there's a ton of data occurring out of the EMR, like wearable data, et cetera. So we already are looking at how you bring that in. If we could do that, then you can run all sorts of, right, disease precise diagnostics and uncover, I'm guessing, lots of things that nobody would have guessed, because how could anybody be trained on the thousands of conditions that are out there unless you happen to run into the specialist in rare kidney diseases because you live in Palo Alto and your mom works for Google?
Thank you for taking this on as your work. My next guest is Dr. Iain Hennessey, or I guess he would be called Mr. Iain Hennessey in the United Kingdom, where he is a pediatric surgeon and the clinical director of innovation at Alder Children's Hospital in the United Kingdom, which is one of the most forward-looking children's hospitals in the NHS. He's a primary figure in integrating frontier technologies into the NHS to improve pediatric care. So he's looking 10 years ahead to figure out what the next big technology is. Mr. Hennessey's focused on quantum computing, primarily through the strategic partnership that Alder has with STFC Hartree Center. He's going to talk about it in the interview. He and his team are betting big on quantum computing being the next big innovation after AI. I hope you'll enjoy this interview with Mr. Hennessey. Quantum technology. It sounds mysterious. Well, quantum technology, we've heard about it. It's the next frontier of innovation, perhaps after AI or even as an adjunct to AI. How do you explain it to a layperson? What is quantum technology?
Well, it's super spooky, I think is probably the best way to describe it. The more you read about it, the more you go, this is insane stuff. I think it is about the closest thing we have to magic as currently exists. But quantum is about how the subatomic realm works and how all the models start to break down as you get smaller and smaller and smaller. And, what they've done with quantum computers is almost hacking these spooky type effects that create new paradigms in how mathematics and computing happen. So as much as a Victorian would probably not understand the silicon chip, we just don't understand quantum computing.
What's a practical example, though, beyond healthcare, perhaps, of
Mhm.
where we think quantum computing could change the way we do something?
Well, it's this very odd thing with quantum computing because the normal way that computers work is by using a sequence of ones and zeros, and your transistors either at one or at zero. But with quantum computing, it can be one or zero at the same time. So it can be in all states and all positions all the time. So the way that you would try and solve a combination lock is you'd go 0001, 0002, 003, and just work through your whole sequence. And that's how our current computing works. It brute forces the answer. Whereas quantum would have all of the dials and all of the positions all at exactly the same time. And then it would collapse down when it finds the solution to this is the answer. So it can basically just do things that would take a long time by classical processes, but you do them all at one time. So the classic thing that they talk about is code breaking. I mean, if you have a fully effective quantum computer with enough qubits within it, then it could just instantly crack any code that we currently have using traditional mechanisms.
So what are you working on at your hospital as it relates to getting ready for application in pediatric healthcare or just healthcare in general?
Well, we're really lucky here in that there's, beside Alderhay Children's Hospital, which is a big children's hospital in northwest of England, with a great big innovation hub, which is what we have behind us here, is that there's a government facility which has two early stage quantum computers at it, and a bunch of government scientists, and they're looking for potential problems we could use to test these computers out on, use new types of mathematics and computing. And they just want problems from us. And the great thing about hospitals, they have a lot of problems. And one of our big problems is actually scheduling. And this is somewhere where quantum computing is an application because they can look at all the different configurations a service could be in instantaneously at the same time and go, this is the one most optimum way that you could deliver this service, the most efficient possible way, where a larger computer would take an enormous amount of time to do something that complex.
Like you say, it's code
Yeah.
breaking. You're breaking the code of how to schedule for an appointment. So interesting.
Yeah. So like where's the best place for all the doctors to be and in what order, given their preferences and at what time? So we started that project and we've been creating the maths behind it with a view to using the quantum computers when they're stable enough to work. So at the moment, the quantum computers, to stabilize them, they need to cool them down to like almost 0.1 Kelvin. We've got like the UK's largest helium balloon deep underground, cools down to the equivalent of minus 270 degrees or something like that, to stop anything from knocking the qubits off and destabilizing them and causing errors within it. So they're not yet stable enough to do the type of mathematics that we want, but we're trying to get the problem into a state that we can then use quantum computing to do that. So we're positioning, which is a large part of innovation, is about getting yourself into position that when the technology ripens, you're just ready to grab it because you've worked out your problem, you're there, you've done the governance, you've got everyone okay with the idea that when it happens, we're going to go for it, which is what we did with chatbot technology back in 2016. All day, we were the first to deploy IBM Watson. We did it with the same government facility. At that point, chatbots were witchcraft, and now they're just an everyday thing. But it's about positioning yourself for when this technology drops, you're ready to go.
So how do you position the technology in a way so that you're ready so that maybe a decade from now, because healthcare traditionally is not so agile and perhaps is so conservative as we think about data and as we think about changing processes and changing the way we do things, workflows. How do you, as somebody at your hospital, do this kind of priming work?
So I think one of the functions of innovation from it is you're constantly horizon scanning and looking for technologies which are emerging, which don't yet make sense, because that's the point where you want to get on the bus just before it makes sense. So you're looking for slightly ridiculous technologies that people are like, sounds a bit flaky. I often find that that's actually quite a nice point to engage with something because it's not proven to work or it's fused a bit flaky. You can normally leverage a lot of in-kind help from people. The minute people prove it works, then they'll charge you. So you got to get in, before you know that it works. So then as it starts to work, you've already got your deal in place and you've got the relationship in place, and everyone's like, well, why are we not involved in this? And it's like, you needed to do it when it wasn't cool. So it's about riding the Gartner hype cycle. There's that initial spike where you ride the initial spike of the hype, but you don't put a lot of resource into it because it will come back down again. And then you make it go dormant, but you keep it ticking along with your relationships. So when it starts to become useful again, you can just rise with it. So I find it's like almost like a two-wave, type of approach to these new technologies. Because we got on boat with chatbots and natural language in 2015, rode the initial spike, then kept it warm, and then now we're using our ambient AI technologies for doing our note taking and everything else. But we were faster than all other British hospitals to take up because it was all worked up, it was all there, it was all good to go. We had relationships in place, and people are happy with doing these type of advanced technological applications because it's a very forward-looking hospital. So I think that's the culture space you want to try and get people into.
What are we going to need to do beyond your center as we get ready for quantum?
I think you've got to have your problems worked up well. In fact, this project that we've done, the difficult bit was actually articulating what our problem was. In most of the sessions I spent with the scientists was trying to explain to them how the hospital works and where our pain points are. And once we'd got through all of that, they actually solved it pretty quickly. But it was painful to get your problem across correctly so they understood what you wanted them to fix. One part is definitely having your problems worked up. The next bit is you've got to work with the technology providers and experts so that they know how to interact with the problem and give them a steer of, if you create that, that will be a good solution. So a huge amount of what you're doing is a translational process between what you know as a problem holder and what they know as a potential solution giver to go, right, okay, this is the problem it's worth solving, and this would be useful if you could fix it in this way.
So thinking backwards to chatbots, had you thought about back in 2015 and 16, the problems that are bubbling up today around whether it's ambient AI technology for scribing and documentation or synthesis of information, like just how prescient were you and your team back then?
So there was something we were pressing on and one bit we weren't pressing on. I didn't fully understand how good they would be at ambient scribing. And that wasn't the primary reason why we got into the chatbot. The concept behind the chatbot was that there's a misconception, I think, that children want to speak to doctors because they just don't. Yeah, because I'm terrifying, cut up children for a living. I've got a beard and bald and all the rest of it. And they don't want to tell me I drag them into my clinic and they don't want to talk to me. But we thought maybe they will want to speak to a chatbot. Yeah, because they speak to their toys, they speak to imaginary friends. Could you create something which is geared towards children that they could chat with and that would be able to ask a structured set of questions and respond appropriately? So we were thinking around the way it could be giving information, helping familiarize people with procedures, talking at a level that could be decided by the user. Like, I want it to be at this level of, reading age. I want it to be given in this way. Now, we saw that in 2015, and that's basically what's happened now. I mean, I configure my chatbot. I want you to be like this. Like, I don't know if you read the E&M banks at all. Yeah. So I've told my chatbot, I want you to act like you're one of the general purpose vehicles from the culture novels. That's how I want you to interact with me. So I love the chat that I get from my from my when I chat with it. But equally for children is like, how do you want to be spoken to? So I think we're quite pressing on that front, but I never even thought about the ambient scribing. And that is actually what is currently the big thing, the big productivity gain that we've got from this, and maybe one of the biggest actual gains we've had from technology in a short period of time, with almost, with a huge amount of uptake, and people really like it. So the quantum side of things, we started with scheduling because it's probably the easiest one, and the data is the easiest to get when it's not as problematic to use scheduling data of a hospital. You're not using patient information. But these new types of mathematics are going to potentially make sensing so much better. You'd be able to do CT scans with an absolute fraction of the radiation because the mathematics that you use to figure out what's happened when that bit of radiation has gone through the body could be so much more advanced that over a much lower dose of radiation, you could extrapolate what's going on with that structure. In which case you could do it in real time, or you could have it done continuously through radiation. I know someone even suggested, and I love this idea, was that you could potentially use gravity waves, which are totally harmless. Because if your sensing is of a high enough resolution, you can use any type of wave, and could you just shine a light at them? So could you create the type of scanning technologies that are as much witchcraft to us now as an MRI scan would have been to an Egyptian? Because when we talk about MRI scanning, it's crazy. We're going to a massive magnet. We're going to line up all the water molecules, and then we're going to let them collapse, and then see what radiation comes out of it. I mean, that's
That's true. You're well positioned because you've got the proximity to partners. You've got the location nearby. You've got the culture built in to think well in advance, the scanning of the horizon to see what's coming next. Any other secrets that you have around how you're thinking so far ahead as it relates to innovation? Because these days, many people are thinking 1 to 2 years ahead. You're thinking 10 years ahead.
Yeah, I think the scale of time that you think over is really, really helpful. And I don't know what American hospitals are like, but an NHS hospital normally thinks in a 1 year time scale, which is firefighting. And you're never going to be able to position yourself in a prescient sort of way with what's coming up next year. People know what's coming up in the next year. But when you start to place a 10-year bet, then you're more likely to hit something. And because especially if other people aren't thinking in the same way. So you can take advantage of the fact that most people are thinking in 1, maximum 3-year time frames, and then start thinking, right, in 7 years' time, where are we going to be? So 7 years' time, I am pretty sure we're going to have quantum computers from looking at the way it's going. And if quantum computers are going to be a thing, and they can do what we think they may well be able to do, would you want to be positioned in that space? And you're like, yeah, because we could sense things and we could organize the hospital much better, and or even drug discovery, the way that you could predict how molecules would interact. You could start, because one of the problems with children's healthcare is that we have much smaller data sets. So trying to do your classic AI approach to modeling a behavior or looking at how a new drug would work is so much more difficult because you've not got enough data. But if you can have a complete paradigm shift in mathematics and computing, then maybe we could get over the fact that we've got much smaller numbers of people and our data is not as good. So we should be positioned in that. And can we position ourselves in that in a way that doesn't actually cost us any money? And we can. So we can position ourselves with a quantum facility, because at the moment everyone's like, well, quantum doesn't work, which it doesn't. So I'm more than happy to give them a problem, because problems are free, and work with them on how could you solve this. And then in 5 or 6 years' time, we'll look quite clever. And if quantum doesn't work, we've not really lost anything. So, and I think that's the benefit of thinking 6 or 7 years ahead, is that you can do that. I mean, it becomes much more difficult when you're actually placing resource bets down, but you can do it without placing resource bets. So why not?
Love that you're thinking 7 to 10 years ahead. I think we need more people like you out there thinking about what's next and placing those bets. Dr. Hennessey, thank you so much. My final guest is Aaron Patzer. He's a highly successful entrepreneur whose products you may have used in other aspects of your life. He was the founder of Mint.com, the online personal finance management tool. He has been an executive at Intuit, which has incredible consumer centricity to help individuals better manage their personal finances. He's now got a big vision to bring that consumer-centered, consumer-focused technology approach to be brought into healthcare to make patient experience in places like the emergency room or the hospital more pleasant for patients and families. I hope you'll enjoy my interview with Aaron. So you've built incredibly successful products outside of healthcare, like Mint. What lessons from those experiences have most influenced how you approach designing products like ER Advisor?
I feel like I've been incredibly lucky in my career. Mint was used by 25 million people, the top personal finance tool in the US and Canada. And then when it was acquired, I became the head of product for Intuit, TurboTax, QuickBooks, Quicken, Mint. Just if you've used those, I've had the privilege of working on things that 200 million people or so have used. And Vital, our ER product, guides you through an emergency experience. We also have an urgent care product and an inpatient product, and we're up to about 7 million patients a year. And so I take a lot of inspiration from consumer design. And I would say one of the first main principles is don't make me work and don't make me think. So by that, I mean, you need to pay very close attention to your funnel, is what we would call it in consumer design. So eliminate any step that is unnecessary. I'll give you a compare and contrast. So with Vital, you register in the emergency room or the hospital or your doctor's visit the same as you normally would. And we pull out of your records a mobile phone number and we send you a text message with a special link. You can think of it like a password reset link or like an airline record locator, but it's unique for each patient. And just to make sure that it wasn't intercepted, it has a time bound on it, just like a password reset. And we ask you for your last name and date of birth, which you have in your head. There's no download. You literally just click a link and it's a personalized web app. So there are exactly 2 steps in this process. And you didn't have to, by contrast, if you were going to do a patient portal like MyChart, you would have to download an app in Google Play or the iTunes App Store. And about 70 to 75% of people will drop off right there. Now you're down to 25%. Then you make them create a username and password. All right, that's work. Now you have to pick 3 security questions. That's part of the MyChart experience. And sometimes a nurse has to be involved to permission you, and then you get into the experience. And so you've added all of these steps or hoops. Don't make people do work. Don't make people type an address, make them or autocomplete an address or make them type a zip code. Eliminate steps. So that's the biggest thing from consumer experience is we care about our funnel, we care about A/B testing, and we don't want to waste a single user, or in this case, patient.
So how do you balance that important design feature, which is around security and privacy, making sure the right person is accessing the right information? I mean, that's presumably what all those questions are. There is an important element around privacy and security. So how do you balance for that?
Mint took 100 million bank usernames and passwords, never hacked. Vital, ultra secure. We do penetration testing all the time. We use these one-time links. The phone number has just been verified by a real human who took it at registration, right? And the only reason we ask you for your last name, date of birth is if they fat fingered it and sent it to the wrong phone number or something. And if you get it wrong, then it'll lock you out. And so it's plenty secure. It's time-based as well. Like this link doesn't exist for 2 years. It exists while you're at the ED or within a certain time window. And you can also geofence it. You can do a lot of things on IP geolocation that help you out in a number of ways. So you can make it plenty secure without adding all this hassle.
So let's talk about the product itself.
When I'm designing for the healthcare system, personally myself, I think, okay, now think of this while I'm just absolutely nauseous and about to vomit. Now think of this while there's 14 crying children in the waiting room. I don't want to do anything more to annoy an already stressful situation. So that means, again, make it as easy as humanly possible. Don't make me think, don't make me work. Extra clarity around the language. We actually test our language around wait times because we provide a range. You're going to be seen by a triage nurse in between 10 and 15 minutes. Okay. Should it be between 10 and 15 minutes or should we do between 2:13 and 2:23? Should we say, and the first number that we present is like the best guess estimate. It's the 50th percentile and the last one's the 90th percentile. Do we say you'll probably be seen by 2:13, but almost definitely by, okay, is almost definitely too strong? Is probably too strong? You should be seen. Does that convey a 50-50 probability? Like we literally wordsmith and test and do user testing and put it out to friends and family and put it out on the internet at like usertesting.com on a dozen different variations to make sure that it's absolutely clear to the widest number of people possible. The other thing we do is we make sure to meet people exactly where we are. So Vital as a web app is web AA compatible. That means if you're blind, you can use it with a screen reader. That means that for the Children's Los Angeles population, 50% plus Spanish speakers, it is in Spanish. It's also in Armenian because there's a big population in LA who speak Armenian, and this has been professionally translated. And even the text message, if it's recorded in the EHR that this is your language, the text message itself will be translated. And how friendly is that versus a typical system, which is like, hey, we know you're scared, you're nauseous, and there's a bunch of screaming kids around. We're going to speak to you in a language that is not your own. How awful is that? Accessibility, I think, becomes even more important. Sharing becomes more important. We've done secure sharing with literally millions of families to keep them informed, and that's also important.
Consumer products are often focused on delighting end users, right? A consumer product, if people aren't enjoying the experience, they're going to choose something else. They have a choice. That's part of the nature of consumer products. In healthcare, my perspective is delighting the end user is often not obvious as a product choice when you're looking at some of the products that are out there. I'm not just talking about the portals, I'm talking about products in general that are consumer facing. You've bridged that gap between consumer and healthcare product. How do you think about convenience, delight, and in those kind of concepts, both in terms of product design, but also measuring and evaluating whether the product is actually achieving those goals, assuming those are goals for you in terms of your product?
Oh my God, this is the biggest problem and area of not strain, but tension in the design of Vital and my life, which is we are such a pro consumer, pro patient, delight everyone application. For example, if you go into a patient portal today, it'll say something like OMCAR, your BUN is 46 micrograms per deciliter. And you're like, what's BUN and what the hell is a deciliter, right? And we change that into something very consumer friendly. Hey, your kidneys look like they're strained. It might be because of the new medication you're on, right? You'll go into a patient portal and it'll say with a radiology report, you have a fracture of the lateral and medial malleolus and your subtalar fragment is misaligned. And you're like, I don't even know what body parts you're talking about. And we say, you have 2 broken bones in your foot. Very consumer centric. But the tension there is, well, that's our doctor to patient translator. I'm lucky enough to have you as a customer. You get all of this. You care deeply about patients, their families, all the kids who are at your hospital and their parents and what they're going through. When I speak to a CFO or a COO, I say, okay, Vital is going to reduce your leave rate. That's the people who are frustrated and just leave the ED by 30%. And we work with some health systems that do millions of visits a year. And so we've reduced 50,000 visits who are going to leave. And I say 50,000 visits, that's a $2,000 visit that you're going to bill for. That is $100 million of revenue or whatever the math is on that. And then I emphasize that people are more likely to stick with your health system, right? So we take your discharge paperwork, which is often 10 or 15 pages of printed information. It's got education in there. It says, thanks for coming to visit this facility. It's not formatted well. Think dot matrix printer and fax formatting. And we pull out the to-dos, basically. You need to see an orthopedic doctor to set your wrists because it's fractured, and we just put a temporary splint on it. You need to follow up with a primary care or gastroenterologist. You need to pick up these medications. Only about 25% of people actually do that with your health system out of the emergency department. The rest are using ZocDoc, Google, going to a competitor, just looking something up online, and they're not going back to your health system. And so we make sure by making it easy, by giving people to-do lists, by reminding them 48 hours, we haven't seen you, make this appointment, we prevent leakage, and that makes the average emergency room a couple $1,000,000. And I'll guarantee this in a contract.
Mint and other products out in the consumer world are known for how they use data to personalize that user experience. Are you doing that with your product?
Sure, we try to personalize as much as possible. I've mentioned our doctor to patient translator. We also, for our inpatient product and upcoming in our emergency product, have what I would call like a continuous AI summary. Hey, you came in for a fall from a ladder and you have ankle pain. We've ordered an x-ray for you and we started blood work. Okay. And then a little later, the x-ray is confirmed. You do, in fact, have a broken ankle. We've put you in a splint and keep your foot elevated. And so it's taking all of your notes, all of your orders, all of the things that it knows about you, all the doctor's instructions, and putting them in very friendly patient language to keep you updated. And that lets, even if you're out in a waiting room or somebody hasn't seen you for a couple of hours, because it's a busy environment and clinicians don't have time. There's literally somebody who might be dying in the next room, that something is in fact happening, and stay on your goals. This is even more important in inpatient. So we pull out, what are your dietary restrictions? You're on a liquid only diet because you have an ostomy bag right now, or we need to see you walk with assistance 20 feet before you can get out of here, and you need to be able to dress yourself. And so by giving people their goals and keeping them top of mind, both for the patient and the family member that they're sharing it with, who may be with them or maybe 3,000 miles away, you can help that patient accomplish those goals and get out of hospital faster. And that has economic advantages, and it makes the patient more comfortable if that's what they want. Does it ever strike you as weird that you can go to Amazon and there's 10,000 reviews for every plastic trinket out there? And that if I was going to get a shoulder surgery, there's no reviews that say, this is a 8 out of 10 pain. This took me 4 months to recover. I'm an actual patient, and this is the things that I wish I had known a month ago now that I've gone through this. I wish they hadn't made the incision in my armpit because that's a sweaty area and I can't wear anything but a tank top. There are these little things that would put patients at ease that are very unique to them. And what if you were going to take that even further and say, don't just show me anybody's comments, show me patients who look like me. In a children's hospital, I don't want to see things for infants if I'm 12 or vice versa, right? And so show me patients like me.
Thank you, Aaron. Thanks for giving us a preview and talking about all the great bridges you've made between consumer health and applying that into patient health.
All right, thank you for joining us for your dose of optimism. Make sure to check out our show notes to get more information about our guests and the work they're doing. Visit our podcast page on the KidsX website to join our podcast community and to learn more about pediatric innovation. Thank you to our sponsors and to our presenting partner, KidsX. Please subscribe wherever you get your podcasts, and remember, it takes a village to make sure our kids grow into healthy adults. So volunteer at your local library, help out at the community center, and if you're so inspired, donate to your local children's hospital. All right, see you next time. The content, views, opinions, and information presented on this podcast do not reflect the views of Children's Hospital Los Angeles or of the sponsors of the podcast.